Welcome back to the Deep Dive. Today we are tearing down a stack of sources on a health crisis that is just massive, it's relentless, and honestly, it's often hidden in plain sight. We're talking about chronic wound care.
It really is the silent epidemic in global healthcare. You know, when most people think of major health challenges, their minds go to cancer or heart disease, maybe acute trauma.
Right, the big dramatic stuff.
Exactly. But chronic wounds, and here we're talking about things like diabetic foot ulcers, pressure injuries, those really complex venous leg ulcers, they are consuming just vast resources and, causing immense patient suffering.
And when you start to dig into the data, the scale of this burden, it just immediately demands your attention. This is not some niche clinical problem. And I think we have to start right there, because if you get the scope of it, the solutions don't really make sense.
That's the perfect place to start. Let's just look at the numbers cited in our sources. In the United Kingdom alone, we're talking about an estimated 1.5 million, maybe even up to 2 million people affected by a chronic wound at any given time.
2 million people. That's a huge segment of the population, just struggling with these persistent, non-healing conditions.
It's massive. And the financial shockwave that comes with that persistence is, frankly, enormous.
So what are we talking cost-wise?
The annual treatment costs, again, just in the UK, exceed £5 billion.
Wow, 5 billion.
Yeah.
Every year.
Every single year, spent on managing wounds that are often just stuck in this cycle of, deterioration and then failed healing and back again.
And I imagine that 5 billion doesn't even tell the whole story.
Not even close. It doesn't fully account for all the indirect costs.
Yeah.
Things like lost work time for patients or their families, the burden on social care, and then the deep sort of personal cost of a reduced quality of life. Hospitalization, and in the worst cases, potential amputation.
So why is it getting worse?
Globally, the whole situation is just intensifying, and it's because we have these two massive demographic trends that are intersecting. First, we have aging populations across the developed world, and second, we have the rising global incidence of chronic diseases, particularly diabetes and vascular disease. And those are the primary drivers of these wounds.
Okay, so we've got a crisis that is getting worse, it's financially crippling, and it's affecting millions of people. But here's the thing that really jumped out at me from this entire stack of research. The central challenge isn't a lack of sophisticated specialist knowledge or some new miracle dressing. It's a delivery problem. It's a failure of timely action right at the most critical moment.
That's it exactly. Our sources, they all collectively zero in on this thing called the knowledge-practice gap.
Okay, define that for us.
It's this profound disconnect between what all the evidence says should be happening, the best practice guideline, and what the frontline clinician actually does on a, say, Tuesday afternoon with a patient. The knowledge is there, but the action is missing.
And that really defines our mission for this deep dive. We're going to try and go beyond the simple diagnosis of, oh, they just need more training.
Right. It's not that simple.
We're going to explore the psychological, the behavioral, and the systemic barriers that stop these frontline generalists from deploying evidence-based care when it matters the most. It's almost like behavioral economics applied to medicine.
It is. We'll explore the root causes of what clinicians call clinical inertia, and then, and this is in the important part, we'll detail the 4 pillars that the sources propose for designing systems that actively empower confidence and action.
So whether you're prepping for a meeting on healthcare strategy, or you just want a really high-fidelity look at why implementing change in these complex medical systems is so incredibly difficult, this is your shortcut. Let's unpack all this, and I think we need to start with the people right at the center of the problem, the generalist provider. Okay, so let's establish the battlefield here. Who is actually responsible for managing the vast majority of these chronic wounds out in the community? Because it's not who you might think.
It's not. It's not the highly specialized wound clinic staff you see on TV. It's the generalist.
And who are we talking about when we say generalist?
We are talking about the community nurses who are going into patients' homes. We're talking about general practitioners, GPs in primary care clinics, the staff in aged care facilities, and allied health professionals like podiatrists.
So people managing incredibly diverse caseloads.
Incredibly diverse. I mean, think about it. They might see a baby with a rash, then an elderly patient with pneumonia, and then have to pivot immediately to a really complicated venous leg ulcer that's been open for, say, 6 months.
And the sources are pretty brutally honest about how the system fails these dedicated people by just stacking systemic barriers against them.
It does. And those barriers really fall into two major categories. You've got education limitations, and then you've got system support failures.
Let's start with education. That seems like the most obvious one.
It does, and formal wound care education is consistently described in the research as, well, limited, even for the most basic management principles. For nurses, the training deficit is particularly sharp.
Yeah.
There's a widely recognized lack of, adequate specialized training in the core clinical skills related to wound care, and that's both at the undergraduate level and the postgraduate level.
And I think it's really crucial to understand why that happens. It's not just negligence, right? It's curriculum compression.
Explain that.
Well, generalist nursing and medical curricula are already overflowing. They're packed. So when a complex chronic issue like wound care has to compete with acute issues, pediatrics, mental health, preventative medicine, all for a very limited number of teaching hours.
The specialized skills get squeezed out.
They get squeezed out. It's an issue of prioritization and time.
That's absolutely right. And what that means in practice is that many nurses, even very experienced ones, end up relying on fragmented training they get on the job or ad hoc institutional procedures. Or, and this is the worst case scenario, simply copying what the last person did.
And that practice could be decades out of date.
Decades, easily.
Okay, so that's nurses. What about for general practitioners? For GPs?
For GPs, the constraints just compound. It's not just that they face inadequate initial training, they also struggle with these really fragmented care pathways.
Meaning they don't know who to send the patient to.
Often, yeah. They lack seamless, coordinated routes for referring to, say, a vascular specialist or a dietitian or an occupational therapist, and all of those are absolutely crucial for effective chronic wound management.
And this brings us to a really critical practical constraint, which was especially highlighted in the UK context in these sources. Money, financial pressures.
Yes. The sources describe practices where, due to just immense demand and increasingly strained financial models, GPs or even whole general practices have had to actually withdraw or significantly limit the wound care services they provide.
Let's delve into that financial mechanism for a second, because that's the real-world consequence of how the system is designed.
It is. In many of these capitation models, where a practice gets a fixed annual fee per patient, no matter how complex their problems are.
Right, so a healthy 25-year-old and an 80-year-old with a chronic wound earn the same amount of money.
Exactly. And in that model, managing a chronic, complex wound is highly unprofitable. It requires frequent, lengthy, high-resource interventions. It ties up staff time that could be spent seeing maybe 5 or 6 less complicated but equally remunerative appointments.
So the system is actually incentivized by volume, not by complexity. The complex wound becomes a financial burden.
A huge burden, and that often leads the practice to offload that patient back onto community nursing teams, or even worse, it forces the patient to try and seek care somewhere else, which just creates more fragmentation.
So when that cornerstone of primary care crumbles under financial pressure, the delays start piling up immediately.
Immediately.
And those delays, those are the true marker of systemic failure. So let's shift our focus to the concrete consequences of this clinical slowness, or what the research calls diagnostic delays. Our sources highlight a really pivotal finding from a Finnish cohort study.
Yes, this study provides the scientific backbone for why this is all so urgent. The researchers looked at healing trajectories and resource use for patients with chronic wounds, and they established a clear, critical physiological threshold.
What was it?
They found that diagnostic delays beyond 42 days, that's 6 weeks, significantly prolonged the healing trajectory. Once you cross that 6-week mark without an accurate diagnosis and a really aggressive management plan, the wound often moves from being complex but potentially recoverable
To what?
to a truly chronic, stalled state.
Let me just process that for a moment. 6 weeks, 42 days. So that means if the initial contact with the generalist, the first few dressing changes, those first steps, if they haven't resulted in a meaningful diagnosis and a path forward within that time frame, the patient is highly likely to enter a prolonged, expensive, and debilitating phase of care.
Precisely. And the cost implications are just stark. The study found these delays were strongly associated with significantly higher healthcare resource use later on.
So we're talking about more hospital visits.
Yes, increased likelihood of hospitalization, the need for advanced interventions or surgical debridement, all the expensive, invasive things we really want to avoid.
Okay, so 42 days is the scientific deadline. Now, for the really alarming piece of information from the sources that kind of anchors this entire discussion, what is the current average diagnostic delay the generalists are achieving?
The sources indicate that diagnostic delays currently average 57 days.
57. That's almost 2 months.
It is.
So the average patient is being diagnosed or escalated for the right management 15 days after that critical 42-day threshold has already been crossed.
That 15-day gap is catastrophic. It really is. It's the difference between catching a simple infection before it progresses to osteomyelitis or identifying the need for vascular intervention before the tissue damage becomes irreversible. This systemic slowness is what traps millions of patients in unnecessary suffering and drives up that £5 billion cost we talked about.
It paints a perfect picture, really. A high-stakes problem handled by undersupported generalists who are operating in a system that often financially disincentivizes the very care they need to provide, all resulting in a systemic delay that basically guarantees suboptimal outcomes.
You've summarized it perfectly.
So now we have to move to the absolute heart of the matter. If the problem is this big and this expensive, why isn't just more education solving this massive gap?
This next section really forces us to move beyond thinking about this as a simple information deficit and into the realm of human behavior and system design. The knowledge-practice gap is not fundamentally a lack of intelligence or competence in our clinicians.
Right.
It's a structural failure to translate that knowledge into reliable, consistent action.
Okay, let's unpack the core behavioral mechanism that's at play here. The term used is clinical inertia. We know the generalist has the knowledge, or at least they can access it, but they just default to the routine.
Yeah.
What's driving that inertia?
Well, often it's driven by the fear of making a clinical error. The sources highlight this fear as a primary influence on patient safety decision-making.
That sounds counterintuitive. Shouldn't the fear of making a mistake make a clinician more rigorous, not less?
You would think so, but let's look at the psychology of it. When you're faced with a complex, chronic condition like a wound, the treatment response is often very delayed and ambiguous.
Right. It's not like treating a simple infection where you give an antibiotic and the fever drops in 24 hours.
Exactly. That's immediate, clear feedback. In wound care, you might make a change today, and you might not see even a 10% improvement for 3 weeks.
So that lack of an immediate, clear feedback loop, it increases the perceived risk of doing something different.
Massively. If a generalist tries a new evidence-based compression bandage and the wound looks the same, or maybe even a little worse, a week later, they may quickly retreat back to the familiar, less aggressive, but safer dressing they learned about in nursing school.
So sticking with what they know, even if it's suboptimal, feels like a lower risk behavior because it's established. It's the standard operating procedure, and it protects them from perceived blame.
It's clinical inertia driven by psychological self-preservation, not by clinical malice. And the psychological toll on the provider themselves is significant. The source material really details this emotional cost.
And this is a critical point that is so often missed in policy discussions.
It is. This fear of error is intrinsically associated with feelings of guilt, of shame, anxiety, and even depression among providers. And it extends beyond just worrying about harming the patient.
It's about their career, their reputation.
Yes, it includes deep concerns about reputation, potential complaints, and even job security if an error is perceived or, actually occurs.
So just to paint the picture, the generalist is operating under intense pressure. They're managing an ambiguous, high-stakes condition with a really poor feedback loop. It just creates an environment where defaulting to wait and see, or continuing with a dressing that is clearly failing, becomes the psychological path of least resistance.
It does. It's the system, not the individual, that is promoting that 57-day delay.
And this behavioral insight is what explains why just running another mandatory annual education module on the latest wound care guidelines is doomed to fail.
Exactly. Knowledge transfer is easy. Behavior change is incredibly difficult. And the research confirms that knowledge does not consistently translate into behavior change, even after really sophisticated educational interventions.
But, and this is a big but, the same research managed to isolate the two conditions that do reliably promote clinical action based on knowledge. This is basically the recipe for overcoming that inertia.
It is. And the recipe is, in principle, quite simple. It's level of certainty and a sense of urgency.
Certainty and urgency. Okay, let's break those down. The generalist must be certain that the current course of action is wrong and that the new course of action is the correct evidence-based next step.
Yes. Absolutely certain. And they must feel a powerful sense of urgency that demands they immediately deviate from that routine. If the environment, the system they work in, does not provide simplified tools to generate that certainty and clear triggers to generate that urgency.
Then even the most knowledgeable clinician just defaults to the routine.
They do. They simply don't feel empowered to disrupt the status quo and take what feels like a personal or professional risk.
So the system has to be designed to generate the certainty and the urgency for them. That is a fascinating application of behavioral economics. Instead of demanding that generalists somehow become specialists overnight.
You design the workflow to eliminate the cognitive effort required to achieve certainty and the logistical effort required to achieve urgency. You shift the burden from individual memory and willpower onto the systemic design.
And we have hard evidence that this approach works.
We have compelling evidence. Let's look at the positive findings from Australia regarding these things called point-of-care nudges.
Right. This is where we see the transition from theory to successful practice. So tell us about these micro-interventions.
The Australian research involved embedding these point-of-care nudges directly into electronic medical record, or EMR systems. These were micro-interventions designed explicitly to reduce clinical inertia in wound management decisions.
So you should think of it less like a big, annoying pop-up warning and more like a helpful, pre-engineered next step.
That's a great way to put it. It's not just a reminder that says, hey, this wound is 4 weeks old. It's something that actively lowers the cognitive barrier to escalation.
Give me an example.
Okay, so imagine a community nurse logs a wound assessment and notes that the size has only decreased by, say, 15% over 4 weeks. That falls below the critical 30–40% threshold we'll talk about later. The EMR doesn't just display a warning.
What does it do?
It might auto-generate the first 3 fields of a referral form to a specialist. Or it might provide a single-click button that flags the case for specialist review within the next 7 days. It makes the proactive, evidence-based step the easiest path to follow.
And the impact. That's what really matters.
The impact was huge. These targeted systemic nudges resulted in a 27% improvement in timely escalation over just a 6-month monitoring period.
A 27% improvement. That's a massive, measurable shift in behavior.
And it was achieved without running a single additional mandatory training course.
So that confirms it. The generalists had the ability to escalate all along. They just lacked the necessary trigger and the certainty that the systemic design provided. This really proves the solution is organizational and behavioral, not merely educational.
It is. It's about making the right choice the easiest and most confident choice.
The goal shift here is just undeniable. We have to stop treating this as an information deficit problem.
And start treating it as an environment design problem. We need to create conditions where timely, confident action is the default and where clinical inertia becomes the cognitive heavy lifting, not the easy way out.
Okay, so we've established the root cause. It's inertia, driven by a lack of certainty and urgency in a really high-pressure environment.
Now, based on all this research, let's transition to the blueprint for closing this gap. And this blueprint is built on 4 core systemic principles designed to support that generalist.
Right, this is all about designing tools and systems that support confident, evidence-based action. The overall aim is crystal clear. Improving generalist performance does not require turning them into specialists.
No specialist transformation.
None. It just requires creating the conditions for timely, confident action.
Let's start with Pillar 1, which to me fundamentally challenges the traditional approach to medical education. It's focus on essential knowledge, not exhaustive education. This is all about actionable awareness. The objective is to equip the generalist with the minimum viable information required to make a critical, time-sensitive decision. They don't need to know every microscopic detail of fibroblast function.
Right. They're not writing a research paper.
They're not. They just need to reliably recognize the red flags and know the basic first steps.
And the sources provide a very specific list of what this essential knowledge breakdown must include. It's almost like a triage checklist.
It is. First, reliable recognition of the common wound types, specifically diabetic foot ulcers, venous leg ulcers, and pressure injuries. If a generalist can accurately categorize the wound into one of those 3 buckets, 80% of the diagnostic battle is already won because the treatment pathway for each is distinct.
Okay, that's step 1. What's step 2?
Second, and this is where that certainty and urgency are explicitly engineered into the system, is understanding the key red flag indicators.
So what are the specific, measurable indicators that absolutely must trigger a change in action?
The primary metric is the failure to heal benchmark. For venous leg ulcers or pressure ulcers, the big red flag is the failure of the wound to improve by 30 to 40% within 4 weeks.
30 to 40% in 4 weeks.
Yes. This percentage threshold is derived from biological research that shows if a wound hasn't achieved at least that level of size reduction, the underlying pathology is not being adequately addressed. Something is wrong.
I want to spend a moment on that 30–40% benchmark. Why is that specific number so important? And isn't there a risk of, clinical gaming where a clinician might just delay measuring it until week 5 to avoid the pressure of that red flag?
That is a highly relevant and critical question. First, the 30–40% rule isn't arbitrary. It reflects the minimum expectation for cellular proliferation and contraction in a properly managed wound. If it doesn't meet that, you know the environment is hostile, either due to infection, inadequate blood flow, or continued pressure. It's a biological fact. Now, to your point about gaming the system, that's where Pillar 2 and Pillar 4 become so crucial. If the system itself, the EMR, embeds digital prompts that demand a measurement at week 4, the system ensures compliance.
So the EMR won't let you close the file until you've entered the measurement.
Something like that. And if Pillar 4 mandates specialist input within 7 days of entry to care, the inertia is broken much, much earlier, which reduces the impact of any delayed measurement.
Got it. So the metric itself is clinical, but the enforcement has to be systemic. What about other red flags?
Beyond the healing percentage, generalists must be trained to recognize the very clear signs of complication. Increasing exudate, that's fluid from the wound, a foul odor that doesn't resolve after cleaning, or clear visible signs of spreading infection, like redness, or if the patient has a fever. These require immediate, high-urgency action.
And the final piece of this essential knowledge, simple next step.
Basic first-line interventions. Knowing the appropriate dressing categories for the wound type, is it highly exudating and wet, or is it dry and necrotic? And knowing the primary indication for key mechanical interventions, like the need for offloading for diabetic feet or compression therapy for venous ulcers, they need a reliable, evidence-based toolkit for those first 30 days.
That leads us perfectly into Pillar 2. Simplified decision-making with embedded tools. This directly addresses the need for certainty and removes that reliance on fallible human memory.
The imperative here is usability and accessibility. Clinical tools cannot live in a binder on a dusty shelf in the office.
Right.
They have to be accessible, easy to use, and critically integrated into the generalist's everyday workflow. The system itself must prompt best practice, minimizing the cognitive load associated with, looking up guidelines or trying to remember complex algorithms.
What are some concrete examples of these tools that our sources recommend?
Firstly, simple visual aids. Things like wound assessment flowcharts. A generalist can just look at the chart. Is the wound deep? Yes. Is there high exudate? Yes. Does it look infected? No. Okay. Follow pathway B. This kind of visual simplicity imposes certainty.
It's reducing a really complex set of differential diagnoses into a binary actionable decision tree.
Exactly. Secondly, dressing selection guides. These provide stepwise recommendations based purely on the observed wound characteristics. It takes all the guesswork out of product selection, and it ensures that the expensive, specialized products are used correctly and appropriately right from the very start.
And the most powerful tool, at least judging by that Australian success story, is leveraging digital technology.
Without a doubt. Digital decision trees or apps integrated directly into EMRs or mobile platforms provide real-time support right at the point of care. Just imagine the community nurse using a tablet to chart the wound. The assessment data they input immediately triggers the system to recommend a specific dressing category and flag the red flag status based on the healing rate. The system does the complex calculation, and that frees up the clinician to focus on the patient.
This shift is it's profound. It moves the generalist from being this solitary, stressed decision maker to being an expert data collector who is supported by an intelligent, evidence-based system.
Yeah.
That has to reduce the fear of error dramatically.
Which brings us directly to Pillar 3. Enable confident escalation and referral. If the red flag is identified and the simple tools aren't moving the wound in the right direction, the generalist must act decisively.
And timely escalation is so vital, yet it's a massive sticking point because of that uncertainty and the fear of crying wolf to a busy specialist team. They're afraid the specialist will just send the patient right back with a note saying you should have tried X first.
That hesitation, That perceived lack of access to a specialist or the cultural barrier of feeling like you'll be judged, that is what fuels the 57-day average delay. So a robust escalation framework has to address the clinical need while actively dismantling those cultural and logistical barriers.
So what defines a clear escalation framework? It has to start with defined clinical criteria.
Yes, this provides the generalist with the certainty they need to initiate the process, and the criteria must be unambiguous. Stagnant healing, like failing the 40% reduction benchmark, or suspected deep infection, or any signs of critical ischemia or arterial compromise. If the patient meets criteria X, Y, or Z, the generalist has a professional mandate to escalate. No questions asked.
Next, you need structured referral pathways. This is what addresses the logistical friction.
Right. This means digitized, standardized referral forms. No more faxing half-filled paper forms across town. It requires predefined triage timelines, which creates that sense of urgency system-wide. The specialist team has 7 days to review and respond, and absolutely clear contact points so the generalist knows exactly who to call and how to send the referral every single time.
And that third element, cultural reinforcement, is arguably the most important for tackling the psychological tool we talked about.
It is absolutely essential. The messaging throughout the entire organization, from the top down, must be clear. Timely escalation reflects good practice, not clinician failure. We have to celebrate the generalist who recognizes the red flag at week 4, not criticize them for needing specialist help. This turns consultation into a reflection of diligence and patient advocacy.
And finally, Pillar 4. This sets the aggressive but necessary operational benchmark. Engage specialists within 7 days of entry to care.
This is a bold goal, I'll admit, especially when the current average delay is 57 days, but it's necessary because it is driven by hard evidence. Early specialist input within that first week or 2 is strongly associated with faster healing trajectories, fewer amputations, and demonstrably lower overall treatment costs. It's preventative economics.
So that 7-day target isn't just some aspirational number pulled out of thin air. It's a systems mandate to proactively break that cycle of clinical inertia and diagnostic delays.
Correct. And the goal is twofold. 1, dramatically reduce the time a patient spends in the hands of a generalist who is struggling without certainty, which minimizes the complications that require hospitalization. And 2, it supports those generalist teams by ensuring they receive timely, specialized feedback.
So it's a teaching moment, too.
It's a massive teaching moment. If a specialist provides input early, the generalist learns immediately what the critical next steps are, and that builds their confidence for the next patient. It creates a powerful, positive feedback loop.
These 4 pillars, focus, simplify, enable, and engage, they really do form a comprehensive blueprint. It's all about shifting the responsibility from the individual generalist to the organization that is supposed to be supporting them. We've established a theory, and we've walked through the 4 pillars. Now let's talk brass tacks. How does an organization take these principles and actually hardwire them into the daily reality of a busy clinic or a community service? This is about the organizational levers designing environments where evidence-based care is just routine.
The emphasis has to remain on system design. We need to create operational environments that support the right actions every single time, making evidence-based care the default while, and this is key, avoiding adding cognitive or logistical workload to already strained staff.
Let's start with consistency, which is often a major challenge because of high staff turnover or rotation between departments. The solution proposed is structured onboarding.
This is a completely non-negotiable step if you want to achieve consistency. Staff, particularly new hires or those rotating through different services, must be introduced early and thoroughly to the essential high-priority elements of effective wound care. This is not just a quick tour of the supply closet.
So what should this mandatory structured onboarding actually contain?
It must include mandatory training, not just on basic dressing application, but specifically on the red flag criteria, that 40% rule we keep coming back to. It must cover the specific escalation triggers, when to stop treating and start referring, and it must include immediate access training for those simplified decision aids we discussed.
So if the digital flowcharts are the backbone of the system, every new staff member has to be fluent in using them from day 1.
From day 1, no exceptions. It builds the system's parameters into that staff member's operating mindset immediately.
And technology, as we saw in that Australian example, is the great enabler here. So the next lever is digital solutions and prompts.
Right. Technology guides timely action without having to rely on an individual's memory. This is where the organization has to leverage its electronic medical record system. We need prompts built right into the system that track patient progress passively in the background.
Give us some specific examples of how these prompts can function as effective behavioral nudges.
Okay, so consider two critical types of prompts. First, a reassessment alert. If a patient has a complex wound and the system hasn't logged a new size measurement or a healing percentage in 30 days, the EMR throws up a mandatory alert. It forces the clinician to reevaluate the trajectory.
It makes it impossible to just let it drift.
Impossible. Second, an escalation reminder. If the logged data shows a healing rate below that 40% target after 4 weeks, the system should trigger an immediate high-priority reminder to initiate the specialist referral pathway. It could even pre-populate the form.
So you're shifting the burden of remembering a complex clinical guideline onto the system itself. The clinician no longer has to mentally track 100 different patient healing curves.
No, the system tracks them, and it alerts the clinician only when a patient meets the criteria for urgency. It automates the sense of urgency by externalizing that time-sensitive calculation.
Which is crucial for sustained change. And that brings us to the next lever. Team-level monitoring and feedback. If you want a behavior to stick, you have to measure it, and you have to make the results transparent.
This is all about moving beyond looking at national averages and using local, actionable data. Organizations should be tracking their own escalation rates, their specialist response times, and most importantly, their local patient healing outcomes. This data is invaluable because it creates peer accountability and drives internal urgency.
And the sources recommend robust data visualization, dashboards.
Yes, dashboards are so effective at driving change.
Why? What's the magic of a dashboard?
Because they provide real-time feedback and they facilitate peer comparison. If a community health district sees its overall average diagnostic delay is, say, 65 days, but Unit A is consistently hitting 35 days, that dashboard visualizes two things at once: what's possible, 35 days, and the urgent gap, that 30-day difference. It highlights strengths, it signals where focused support like coaching or resources is needed, and it provides social proof that improvement is actually attainable.
So the dashboard acts as a kind of transparent, non-judgmental performance manager. It keeps teams aligned and drives improvement through a bit of internal competition and shared goals.
It takes clinical performance data, which can often feel really abstract and personal, and transforms it into a concrete team-level focus. And that leads us to the final lever, which addresses the emotional side of practice, a culture of recognition.
And this directly tackles that psychological toll we discussed earlier, the guilt and the shame associated with perceived error or a lack of knowledge. So how do organizations foster a culture that reinforces good, proactive practice?
By celebrating the correct behaviors, not just the successful outcomes, this means creating structured and informal ways to recognize staff who use the new system to break that clinical inertia.
So like informal peer shout-outs.
Exactly. A quick public acknowledgement during a staff meeting that says, "I just want to thank Nurse Patel for using the new 7-day pathway on Mrs. Smith." Those are incredibly powerful.
And the sources also emphasize sharing short, local examples of positive outcomes that happen because of timely intervention.
That's how you build and reinforce confidence. When clinicians hear or see a real story about a positive outcome, because Dr. Jenkins escalated a potentially infected diabetic foot at day 5 using the digital criteria, we were able to prevent an amputation, it reinforces the message that proactive, confident action works.
It replaces the fear of error with the confidence of success. It completes the behavioral cycle.
It does.
So by combining structured training, digital guidance, transparent measurement, and a culture that rewards proactive, evidence-based action, organizations can effectively engineer an environment where clinical inertia is finally overcome. And that 57-day delay becomes a relic of the past.
The systems design approach is really the only way to tackle a problem of this magnitude. It acknowledges that generalists are absolutely essential, but the high complexity and cognitive load of chronic care demand a specialized, supportive, operational framework to help them succeed. #OutToRectorus.
You know, this deep dive has fundamentally shifted my perspective on chronic wound care. It's not just a clinical failure, it's a systemic behavioral failure. And it's driven by environments that prioritize routine over urgency. The core takeaway for you, the listener, has to be this necessary paradigm shift. To close the chronic wound care gap, we have to move from simply distributing more information to actively designing systems that ensure confidence, not complexity, defines chronic wound care for the generalist.
That's it, exactly. Generalist providers do not need to have specialist-level expertise. What they need is clear guidance, timely feedback, and accessible embedded tools that simplify the complex decisions inherent in wound care. The organizational levers are proven to work. That's structured onboarding, the digital EMR nudges, unit-level audit feedback cycles, and a culture that rewards, not punishes, escalation.
And by embracing these principles, and specifically by setting that audacious but evidence-based target of engaging specialists within 7 days of a patient entering care, healthcare systems can drastically reduce those 57-day average diagnostic delays, mitigate these rising financial burdens, and profoundly improve patient healing outcomes.
We've seen that the behavioral solution works. I mean, if embedding simple point-of-care nudges in a system can drive a 27% improvement in timely action and reduce clinical inertia over just 6 months in one area of chronic care, just think about the broader implications.
And that is the final provocative thought for you to consider as you reflect on this data. What other chronic high-stakes areas of healthcare delivery, from, say, managing high blood pressure to preventative cancer screening, that currently suffer from clinical inertia, could benefit from this same focused behavioral and systems redesign approach?
Where else are we failing to translate known knowledge into necessary action?
And how can we use certainty and urgency to solve it?
That is the challenge of modern healthcare delivery. Thank you for joining us for this deep dive.
We'll see you next time.